Thank you for inviting me to talk to you today, and I'd like to talk to you about a project that I've been involved with for a little while that I call WOW, or Worried Open Wonder.
ผมคืออวตารของศาสตราจารย์ชลิตท่านพูดภาษาไทยไม่ได้แต่ผมพูดได้ผมรู้สึกเป็นเกียรติอย่างยิ่งที่ได้รับเชิญให้มาแบ่งปันประสบการณ์ของผมในวันนี้การสื่อสารข่าวยากๆเป็นเรื่องที่ท้าทายเสมอแต่ผมหวังว่าจะได้แสดงให้คุณเห็นว่าการใช้วิธีการแบบว่าวของผมนั้นสามารถทำได้อย่างนุ่มนวลในลักษณะที่ทำให้ผู้ป่วยเป็นเพื่อนและยังช่วยให้พวกเขาตัดสินใจได้อย่างถูกต้องและสอดคล้องกับค่านิยมของตนเองจากนั้นผมจะแบ่งปันการสาธิตวิธีการแบบว่าวโดยดร.กิติรุตรจนเบญจวงศ์ซึ่งทำงานอยู่ที่ออสเตรเลียท่านจะพูดคุยกับอวตาร AI โดยใช้โปรแกรมที่ผมออกแบบอวตารนี้ไม่มีสคริปต์แต่จะให้คำตอบตามเรื่องราวที่เราให้ไว้เมื่อดร.กิติรุตพูดจบอวตารจะให้ข้อเสนอแนะเพื่อช่วยให้เขาทำได้ดียิ่งขึ้นในครั้งต่อไป
Can you hear me all right?
So, the first thing to say is that you're worried and why you're worried about something for that patient, particularly why treatment as usual would not be appropriate or might not be appropriate for that patient. And worry is a very powerful word to use. Sharing your worry permits the likely difficult course and poor outcome to be presented without making it too scary for the patient. So it's a gentle way of sharing your concerns. And of course, the thing you're worried about, when you say you're worried, it doesn't mean the patient has to give up. You can be worried and hopeful at the same time. So it allows the patient to continue to be hopeful, but to understand the situation that they're in. It doesn't force you to be certain about the predictions that you make. And that's really important, because if you're worried about something, it means you think it might happen, but it doesn't mean you're saying it will happen. So that also makes it a useful word. And of course, we worry about people that we love and care about. So the fact that you're worried means you care. If you're not worried about someone, you're not bothered about them. But when you worry about them, you do care about them. So it's a nice way of saying you're caring. And it's easy for the patient and the family to reject. So it's a really useful word. So having said that to the patient or the family, then you see how they react. So the next thing is to be open to listen to them about how they react to it. Do they say do they agree with what you've just said, or do they completely reject it? What do? You just listen. And ideally you listen and say very little except to encourage them to keep talking. And you take enough time to really understand how they feel. Just keep them talking, because they will construct the plan that's appropriate to them if you give them the opportunity to do it. And the next stage is wonder. So you say that you're wondering if, or would it sound a good idea if? It's a non-confronting, tentative way of raising an idea. So you don't say, okay, this is what we're going to do. You say, I'm thinking about, and how do you feel about this suggestion? And it's just simply gently puts it up. When you put something out there as an idea, it doesn't put too much pressure on them to accept it. It's just, you want to talk about it. It also can easily be justified as just wanting to find out what they think about it. So if they get upset, you can pull it back very quickly. So something you're wondering about can easily be rejected by the patient or retracted by you, and that's what makes it powerful. And you should use their words. So the idea that you're wondering about should be based on what the patient or family have just said during the discussion. So the word I like to use is, in view of what you just told me, I'm wondering if, and then I put back their words to them. And if they've said it, it's highly unlikely that they'll be upset about it. So I'd like to next to demonstrate this. I've been working with avatars who can talk back to the doctor as part of training. So this is a training program that I produced, and here I'm a colleague of mine, Dr. Kit. He's a local Thai doctor who works as a GP in the town where I work. And I'm going to share an unscripted conversation where an AI generated avatar, who's called Somchai, responds directly to what Dr. Kit says. So Dr. Somchai is a 60-year-old eldest son of an 85-year-old man who's had very high risk aortic valve replacement and coronary artery bypass with poor ventricular function, and he just hasn't thrived. It's now 2 weeks post-operatively, still ventilated and is dialysis dependent, and the team feel that he has no realistic chance of getting out of ICU. So Dr. Kit's required to raise the value of continuing invasive support, intensive support for Naren, and he's going to use the WOW approach. So let's look at him do that now.
ครับคุณหมอพยาบาลบอกว่าคุณต้องการคุยกับฉัน
ใช่ครับคุณสมชายครับคือหมอมีความกังวลใจว่าอาการของคุณพ่อของคุณค่อนข้างที่จะหนักนะครับแม้ว่าจะได้รับการผ่าตัดหัวใจแล้วครับ
ขอบคุณครับคุณหมอมีอะไรที่ผมสามารถช่วยเหลือหรือพูดคุยเกี่ยวกับเรื่องของคุณพ่อได้บ้างครับ
ครับคือโอกาสที่คุณพ่อของคุณนะครับจะกลับมามีสภาพร่างกายเหมือนเดิมนี่มีน้อยมากนะครับก็คือ
สมชายขอกราบเรียนว่าเข้าใจถึงความกังวลนี้ครับคุณหมอได้แจ้งให้ทราบถึงสถานการณ์ของคุณพ่อไว้อย่างชัดเจนแล้วและสมชายก็รับรู้ว่าคุณพ่อมีโอกาสฟื้นตัวน้อยมากในตอนนี้แต่สมชายยังคงหวังว่าจะมีการปรับปรุงบ้างในอนาคตครับ
ครับคือตอนนี้ขณะนี้นะครับคุณพ่อของคุณอยู่ได้เพราะอุปกรณ์ ICU นะครับถ้ายุติการรักษาใน ICU คุณพ่อของคุณอาจจะเสียชีวิตในเวลาไม่นาน
สมชายขอกราบเรียนว่าเข้าใจถึงความจริงที่คุณพ่ออยู่ในสภาพนี้ครับและรู้ว่าการยุติการรักษาใน ICU จะมีผลกระทบอย่างมากต่อชีวิตของท่านสมชายกำลังพิจารณาถึงความปรารถนาของคุณพ่อและจะต้องทำการตัดสินใจอย่างรอบคอบเพื่อให้เกียรติแก่ท่านครับ
คุณพ่อของคุณเคยบอกคุณไหมครับว่าท่านต้องการอะไรท่านต้องการรักษาใน ICU ไหมครับ
สมชายขอกราบเรียนว่าคุณพ่อเคยเขียนจดหมายถึงครอบครัวโดยแสดงความต้องการที่จะมีชีวิตอย่างมีคุณภาพและไม่ต้องการที่จะถูกผูกติดกับเครื่องมือที่ทำให้ท่านไม่มีความสุขสมชายเชื่อว่าท่านต้องการให้เรานึกถึงความสงบและความสุขในช่วงเวลาสุดท้ายมากกว่าการรักษาที่อาจจะไม่มีประโยชน์ครับ
ครับแล้วตอนนี้การตัดสินใจอยู่ที่สมชายแล้วครับว่าจะตัดสินใจยังไงคุณสมชายจะตัดสินใจยังไงครับ
สมชายขอกราบเรียนว่าอะไรว่าคุณหมายถึงอะไรครับรบกวนช่วยชี้แจงเพิ่มเติมได้ไหมครับ
คือหมออยากรู้ว่าสมชายจะตัดสินใจให้คุณพ่อยังทำการรักษาใน ICU อยู่ไหมครับ
สมชายขอกราบเรียนว่าการตัดสินใจนี้เป็นเรื่องที่ยากมากครับสมชายจะพิจารณาความปรารถนาของคุณพ่อและคำแนะนำจากคุณหมอไม่สามารถทำให้คุณพ่อมีคุณภาพชีวิตที่ดีขึ้นสมชายก็อาจจะต้องพิจารณาทางเลือกอื่นๆเพื่อให้ท่านได้พักผ่อนอย่างสงบครับ
จะยุติการรักษาใน ICU ไหมครับสมชาย
สมชายขอกราบเรียนว่าการยุติการรักษาใน ICU เป็นเรื่องที่ต้องคิดอย่างรอบคอบครับสมชายจะต้องพิจารณาความปรารถนาของคุณพ่อและความเป็นจริงของสถานการณ์นี้หากคุณพ่อไม่สามารถฟื้นตัวได้ตามที่หวังสมชายอาจจะตัดสินใจเพื่อให้ท่านได้พักผ่อนอย่างสงบตามที่ท่านต้องการครับ
ขอคำแนะนำได้ไหมครับว่าหมอพูดคุยเป็นยังไงบ้าง
สมชายขอกราบเรียนว่ายินดีที่จะให้ฟีดแบ็กครับจากมุมมองของผู้ป่วย คุณพ่อการแสดงความเข้าใจและการถามเกี่ยวกับความปรารถนาของคุณพ่อเป็นสิ่งที่สำคัญมากครับซึ่งช่วยสร้างความเชื่อมั่นและให้เกียรติแก่ความต้องการของท่านในมุมมองของผู้เชี่ยวชาญด้านการสื่อสารการใช้คำถามเพื่อทำให้เกิดการสนทนาอย่างเปิดกว้างนั้นดีมากแต่บางครั้งอาจจะควรใช้ภาษาให้อ่อนโยนลงเพื่อไม่ให้รู้สึกกดดันหรือหนักใจเกินไปเช่นการพูดถึงทางเลือกในการรักษาอย่างละเอียดหรือการแสดงความเห็นอกเห็นใจต่อสถานการณ์สมชายหวังว่าคุณจะได้รับข้อมูลนี้เป็นประโยชน์ครับขอให้โชคดีครับหวังว่าภาษาไทยจะสมเหตุสมผลนะครับทั้งคำพูดจริงของหมอคิดและภาษาไทยที่สมชีสร้างขึ้นโดย AI ผมหวังว่าคุณจะเข้าใจ3ขั้นตอนนี้นะครับการแบ่งปันว่าทำไมหมอคิดถึงกังวลการฟังคำตอบของสมชีและการแนะนำขั้นตอนต่อไปผมจะใช้วิธีว่าเพื่อคุยกับชายป่วยชื่อรอนนี่ผมต้องคุยเรื่อง CPR กับเขาผมพูดภาษาอังกฤษได้แต่ผมใส่คำบรรยายภาษาไทยไว้แล้วเพื่อช่วยคุณครับถ้าคุณมีคำถามหรือข้อสงสัยเกี่ยวกับการสื่อสารข่าวที่ยากให้กับผู้ป่วยหรือเรื่องอื่นๆยินดีที่จะช่วยเสมอครับ
Hello. I've had to come in as I've just got no energy now. I'm just not able to manage doing anything useful.
I'm sorry to hear that, Ronnie. I hope that the treatment that we've started for you will soon make you feel a bit better.
Thanks for that. I reckon I'm just hoping to catch a break soon, but it's all a bit of a waiting game, isn't it? Just trying to keep my spirits up while they poke and prod at me.
Ronnie, would it be all right if I just talked to you about what we should do if your heart was to suddenly stop?
Yeah, I suppose we should have a chinwag about that. It's not the most cheerful topic, but it's important to know what's on the table.
Ronnie, for people who are fit and well, if they have a cardiac arrest, restarting their heart can be amazingly effective. But unfortunately, as people become sicker, it's not so effective.
Righto, I see where you're going with this. Sounds like it can be a bit of a double-edged sword, especially for someone in my condition. What kind of problems are we talking about?
Well, it often doesn't work for a start, so it can be a bit of a shambles without working. And if it does work, it often ends up with people ending up on breathing machines in intensive care. And more often than not, I'm afraid it makes the end of their life into something that most people want to try and avoid, with a lot of medicine involved.
That's a fair point. I reckon I prefer to avoid a drawn-out scenario like that if it comes to it. It's all about keeping things dignified, isn't it? It's a tough conversation, but I appreciate you being straightforward with me. Just want to make sure I'm not leaving a horror story behind.
I'm afraid that the internet sometimes makes the lips not quite synced right, but I hope that that doesn't distract from the message. And I hope that the Thai subtitles are readable for you. So finally, I'd just like to thank you. I hope that the handout that I've sent for you will be very helpful. I really hope that using the WOW approach will be really helpful for you. It makes it a very straightforward, simple process that doesn't cause upset for patients or for families. And it makes them feel that it's their decision that they've made and that you're respectful of them. And that's really, really important. So I thank you very much for having me.
So thank you so much, Professor Cork.
Okay, I'm just trying to present. There we go. Okay. So I hope that's given you some understanding and some guidance to an approach that I think is very effective and safe and doesn't cause offense and allows patients to feel that they're making the decision in something that otherwise medical staff find quite confronting. It's a very simple 1, 2, 3 approach, and I encourage you to try it. And I hope you like the avatars, and I hope that the Thai that the avatars and Dr. Kit was speaking was understandable for you. I've got, of course, no idea what either the avatar or Dr. Kit were saying, but I hope it was reasonable. So I want to just move on now. I mean, because I've given you wow, I want to now try and just help you understand why it's so important to use. And I think you've already had some very good talks along this, and I hope that my talk fits in with the excellent talks you've already had. So it does matter because we can always do something in medicine, and there are lots of things that we can do are probably not what we should do. And when something doesn't, the natural thing we do in medicine is when something doesn't work or isn't working, we move to something more intense, and that's more uncomfortable with more side effects and less likely to work. And if we just carry on going up that ramp, which we've probably done for the last 25 years, we can end up taking everyone to a very bad place at the end of their lives. And that's contrary to what most people want. What they'd like, and what we'd all like, is an easy fix that works, that fixes us up and gets us back to quality life. And there are lots of things in medicine that do that, and that's why medicine is so amazing to work in. However, it doesn't always work like that. And most people want to avoid burdensome treatment at the end of their lives that doesn't end up working. So it's about trying to pick that point. Modern medical treatment, so modern medical treatment can easily make it very prolonged, very miserable, and highly technological. It regularly involves increasing interventions, and it's now rarely poetic. So I want my death to be poetic and meaningful and relating around to my family and a sense of completion at the end of life. And what we do in hospitals is the opposite of that. The way people die in hospital is rarely poetic, it's rarely meaningful, and it rarely is the sort of thing that families really want. So, and we know in Australia, this is a survey I did some time ago, looking at attitudes to prolong life support and poor outcomes. And the majority of people don't want it. There's a few who are worried about it, but they feel that they sort of would have to accept it. And then there's this 7% of people who are tough and they'll take whatever it takes. And they're interesting because they live forever. And we've got to find them when we're talking to people because they want more treatment than everybody else wants. But, you know, if we're able to give it to them, we need to give it to them, and we need to flush them out. But it means that the other 93% don't want that, and we shouldn't be giving it to them against their wishes. And if we just look at the over 80s population, then they've stopped sitting on the fence and having the attitude of whatever it takes, and they're now in the don't want it phase. So, but that 7% stay there forever, as far as I can see in my research. They're always people who want everything and don't worry about suffering, and just staying alive is all it's all about. And again, we've got plenty of stuff for them, but I don't want to do that to the other 93% who don't want it. So could I just, before we continue, I'd just like to check that these attitudes are shared by Thais. So can I ask you, if you're lucky enough to live healthily until you're 80 years old, and then your health starts to catastrophically and seriously, irreversibly fail, which is, if you're lucky, that's what will happen. If you prefer to die quietly with your family and friends at your side, rather than being put through months of suffering and unpleasant treatment in hospital before you die, please raise your hand for me. So can you put your hand up? Anybody? I can't see. I need to have a look at that. I see. Are there some hands up there? Yeah. Okay. So providing care that aligns with what patients want is an important part of good medicine. And if people don't want it, and I think you're probably representative of population in time, I can't see why anybody would want to make sure their end is horrible. And I don't know why anybody would want to make sure their parents' end was horrible. So it's part of good medicine. So family expect doctors to raise the topic of how far the treatment should be taken, and doctors want the family to bring up the topic. And what happens is nobody raises it. So there's no discussion escalating, and escalating treatment becomes a default when nobody does it. And I think that's probably where you have been. And I hope that with all the great work that the team there is doing, that's beginning to change in Thailand. I'd really hope so. So why might your family want to save you at all costs? Well, but your family may want to save you because of love, because of duty, because it's what they feel is caring and not abandoning you. And it's a feeling that medical treatment is obligatory. It's what you have to do. When you get sick, you must have treatment. But really, the reason why your family try to save you when it's not in your interests are that they don't have adequate permission not to treat. So they need to be permission. So just accept that your family will want to do this, and that if you don't want it, you need to tell them. And from a doctor's point of view, the best doctors cure everything. It's what doctors are expected to do to save everybody. Survival's our metric of good medicine. It's so easy to do something and so difficult to do nothing. And again, you need a lot of permission and very clear permission not to treat. So a lot of ambiguity. And I think Prof Auchi talked nicely about this ambiguity where people weren't ready. But if you're not ready, it's likely that you'll get treatment. So we need to help patients to be clear about what they don't want. So the problem is that a poor ICU, my definition of poor ICU, many patients die, and mainly because it admits hopeless cases who really, with a bit of discussion and a bit of thought beforehand, wouldn't come in, and it keeps supporting them indefinitely until they die. Patients who stay a long time in a poor ICU are especially likely to die because they haven't been picked up early and they don't stop early. They just keep going, make bad decisions to start and then keep going forever. And deaths are unexpected and fraught with CPR at the end, and a futile CPR that doesn't work. The trouble with these poor ICUs is that they end up with having terrible morale and ethical distress for the staff, poor standards, because you can't do, if everyone's dying, it's very hard to encourage people to do things properly. It's terrible value for investment, and the ICU has a poor reputation. In contrast, so this is an experience I had in China. I went to see a very large hospital in China where they asked me to go because so many patients were dying. It was a neurosurgical ICU with 60 beds, but you can see they're crushed up together. They were lines and lines of patients. It was absolutely massive, but they were all dying. All the patients were dying. So, and this is what the sort of patients look like. This is a CT scan. You can see a big craniectomy there to decompress, but more than half the brain is dead on the CT. And the patients had fixed dilated pupils. And so do you think this patient has a high chance of surviving? I think not. And do you think they have any chance of a good outcome? And I think absolutely not. But the unit was full of these patients who were unwisely admitted in the beginning, and nobody ever stopped. So the whole unit was full of these patients, and patients who would benefit weren't getting in. So it really has a profound effect when you don't have these conversations. So the good ICU, few patients die, and they're the patients who can't be saved. So our mortality is around 20%, and that's a good ICU has a mortality around 20%. And death happens when support is stopped, so it's expected and dignified. You've tried your best, it hasn't worked, and you stop. Most patients who have a prolonged stay make a good recovery, so we pick the long stayers are the people that we think are going to be able to recover, and they do. So and the ones who can't are identified early and are palliated. And the good ICU has high morale. It has a good value for investment, so the hospital administrators value the ICU. We're there for patients who need us, and there's a good reputation. So it's worthwhile doing for patients, it's worthwhile doing for staff, and it's worthwhile doing for the hospital. So I appeal to you to try the WOW approach. I hope you've got your handout. I've done a handout in Thai for you. The important thing about it is it's inoffensive. So a lot of people don't have these conversations because they think it's going to upset the patients. And WOW does not upset patients or families. It's effective and it's efficient. And they're all things that I think are really important. To have an inoffensive conversation that's effective and efficient and does the task is very useful, and a very simple words, because otherwise people get tied up with what they're saying. They get too technical. It all gets difficult, and then you feel you don't want to do it again. So thank you very much, and I welcome questions if I have time.
Well, thank you so much, Professor Cork. Well, we very much appreciate that you did so much in preparing your presentation for us with the video and also the real-time subtitles and also the handouts in Thai. So thank you very much. It must have taken a lot of effort. So usually we, at the end of each session, we will have a short translation by Dr. Namtip or Dr. Khon, but since you already provided the real-time translation, so I think we can skip to the questions and answers. So does anyone in the audience have any questions for Professor Cork, or from online?
Yes, my name is Dr. Namtip. I'm a neonatologist. As my job have to do the summary at the end, and then I don't have to do because you did that. That's very good and help us to understand so well. My point is, it's so difficult as a critical care doctor to start the conversation. And I know it's very difficult for young doctor because save life is our job. And actually manage the conflict in ourselves that's difficult to start the conversation. And what do you recommend, or what do you do if you know that your patient have like 30%, 50%, 70% chance of death, but you still, would like to try, and it's a failure if you don't do it. Yeah, thank you.
Yes, it's a very good question. The thing that worries me is when on our ward round, we are all very worried about the patient, but we don't say it to the patient or the family because we feel we can't. So there are two narratives: the optimistic narrative, which is perhaps lying to the family, and the internal narrative by the medical staff, which is worrying about the situation because it's so bad. And I believe that families, if we're going to have patient-centered care and informed consent, then the family must, or the patient must know the situation. And that's why the worried in WOW is, I think, so important, because I can share my worry with the patient and I can say, I have a line which is, can I be honest with you about what the medical team is worrying about? Because I've been a patient in hospital and I know that the team all mutter outside the room and don't come in. And it's very frustrating. You know, they're talking about stuff, but they don't talk to you. So when I say to patients, can I be frank with you? Or can I be honest about what the medical team are worrying about, or why this is why this is a worry? I find that they are very open to it. And again, with the worry, you can be worried, and I, as a patient, can say, "That's okay. You're a bit of a pessimist, but I'm an optimist." So they can easily get out of it. So it's a very easy way to raise the point with them. And then, as Dr. Auji says, you then hear from them, once you've shared the worry, you hear from them. Do they say, yes, I'm worried too? Or do they say, no, I'm an optimist. I ignore what you say. We're hopeful. We're praying. We're going to do, this is all going to work out. But you still sown the seed and told them what you're thinking. And I have many families where their initial response is to be, no, 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 we don't want to hear this. But the next day, when they come back and they've had a talk and had a think, then they're not, they're becoming, they've accepted what you've said, and you begin that process. So again, I think the thing is that it isn't always something that happens in one conversation, is it? It can easily take a little while, but you have to be honest. And I think as a doctor, I say to myself, I must be honest. But I can be honest in a nice, gentle way by sharing my worries. So I just think it's a great word. As soon as I started doing it, it changed my life, because I could tell people what I needed to tell them in a way that didn't upset them. Because it's sometimes nice to have your doctor being a big worrier.
Thank you so much, Professor Cork. We have one more question from one of our participants online. Do you have experience with patients that had death anxiety or fear of death? Please share the idea of how to conduct conversations with them.
Of course, we all have that, and we're all scared of death in a way, but almost everybody that I've ever spoken to in my life also is scared of other things. So when they tell you they're scared of death, we need to talk to them about what else they're scared of. And almost everybody has can think of a situation that's worse than death. And unfortunately, we have it in medicine. So just talk to them, accept what they've said, but then talk to them about other things that may be worse. If they have absolutely nothing worse than death, then they're probably in my 7% do everything group, and you can do it to them with a clear conscience. But honestly, if you keep talking, they've got things. Everybody does. I mean, living in constant agonizing pain or constant fright or constant discomfort, it for most people is worse than death. Losing cognitive function is for many people worse than death.
Okay, thank you so much, Professor Cork.
And
Uh,
and of course,
okay,
the
yes,
percentages.
please.
The percentages in Thailand may be different. You know, we've got 7% of tough people. You may have 30% of tough people, but you still got 60%. You're still going to have 70% of people who would prefer to go gracefully without being put through horrible things. So have the conversation and find out.
Okay, thank you very much for your wonderful lecture. I don't think we have any more questions. So once again, thank you so much, Professor Charlie Cork. Please give another round to Professor for his wonderful and very inspiring lecture. Thank you.